1-year-old male presented with complaints of progressive weakness in both lower limbs and upper limbs for 8 months, tingling sensation and burning pain in both lower limbs and soles for 7 to 8 months, and pain in both upper and lower limb for the same duration. The weakness was insidious in onset and gradually progressive, beginning with bilateral lower limb in the form of difficulty in getting up from squatting position and difficulty in climbing stairs, which was associated with buckling of the knees. So it was suggestive of the involvement of the proximal muscles. And in upper limb, weakness was since last 4 to 5 months, and there was difficulty in holding the objects in hands and buttoning, unbuttoning, that was suggestive of the distal muscle involvement. So in the lower limb, involvement was the proximal muscle, and in the upper limb, involvement was the distal muscles. During illness, he was able to raise the hands above the shoulders, and there was no any history of slippage of the slippers from foot or foot drag. So there was no proximal weakness in the upper limb and no distal weakness in the lower limb. And there was history of weight loss, which was around 6 kg in last 6 months. There was no any history of diurnal variation, no history of bladder bowel complaints and bend-like sensation, no history of any backache or neck pain. There was no any history of numbness or feeling of reduced sensation by the patient, no history of suggestive of involvement of the extraocular muscles. There was no history of Raynaud's phenomena, alopecia, photosensitive or oral ulcers, no history of fever, rash over sun-exposed part, and no history of joint pain, swelling and stiffness. No history of diabetes, hypertension, thyroid or any other chronic illness. No family history. Patient was chronic smoker and there was history of 40 pack years and he was chronic opium addict. So our provisional diagnosis, as there was involvement of the proximal muscle in the lower limb and distal muscle in the upper limb without any sensory complaint by the patient, and our provisional diagnosis were maybe there is polyneuropathy, but against the polyneuropathy was the proximal involvement of the lower limbs. Myopathy, that was in the lower limb there was involvement of the proximal muscle that was favoring, but the distal muscles involvement in the upper limb that was against the myopathy. Inclusion body myositis we thought because the patient was of the old age and there was significant involvement of the proximal muscles of the lower limb, and mononeuritis multiplex. These were our differential diagnosis. On examination, his vitals were normal, pallor was present and there was mild bilateral pedal pitting edema. There was no icterus, clubbing or lymphadenopathy. CNS examination, his mental function were normal, cranial nerves were normal, muscle bulk, there was only slightly reduced in distal part of the bilateral upper limbs and proximal part of the bilateral lower limbs, but there was no significant reduction of the muscle bulk and tone was normal. On examination, in the upper limb, there was distal muscle weakness and 60% of the hand grip in the bilateral upper limbs, and in the lower limbs, hip flexion and abduction power was 3/5 in the right and left lower limb. So there was proximal weakness on examination in the lower limb and distal weakness with reduced hand grip in the upper limb. DTR were reduced and bilateral plantars were mute. On examination, there was no any sign suggestive of upper motor neuron type of weakness, and on the sensory examination, there was normal sensation of the pain, temperature, touch, position and vibration sensation all over the body. Although there was positive symptoms like tingling and pain was complained by the patient, there was no any cerebellar sign or no any type of spinal tenderness on palpation. So it was a case of insidious onset, gradually progressive, symmetrical, lower motor neuron type of weakness with proximal involvement in the lower limbs and distal involvement in the upper limbs without any sensory, cerebellar, cranial nerve, mental function, bladder bowel and extraocular muscle involvement. So our differential after examination were myopathy, as there was no any significant reduction in the muscle mass with proximal involvement in the lower limb, mononeuritis multiplex, inclusion body myositis, polyneuropathy, and on examination, as there was no any sensory finding, so LMN predominant motor neuron disease. On the basic investigation, his hemoglobin was reduced ESR was significantly raised and it was 120 mm per hour. On liver function test, there was significant AG reversal. Albumin was 3.22 and globulin was 4.3, and there was mild proteinuria. ANA was negative, as well as the history of autoimmune disease was also negative. On further investigation, his CPK was normal, LDH was also normal, but serum calcium was significantly elevated, that is 13 milligram per deciliter. PTH on 2 occasions was normal, so it was non-PTH dependent hypercalcemia, and there was microalbuminuria, that is 342 milligram per day. So there was proteinuria with hypercalcemia without elevated CPK or LDH. On chest X-ray, there was a focal haziness with irregular borders in right upper zone. So we thought that this is hypercalcemia, which is not due to hyperparathyroidism. So it may be due to malignancy, and all these muscle weakness may be paraneoplastic. So symptoms were weakness and weight loss, and on examination and lab finding, there was anemia, raised ESR, hypercalcemia, proteinuria with upper zone opacity in the chest X-ray and hilar lymphadenopathy. So our differentials were malignancy with paraneoplastic myopathy and neuropathy, sarcoidosis as there was hypercalcemia with hilar lymphadenopathy, and multiple myeloma with involvement of the neuropathy and myopathy. These were our differential diagnosis. On CT thorax, the lesion was of the mixed density with partly solid and partly ground glass component, and that was suspicious of the malignancy. So biopsy was advised, and there was diffuse osteoporosis. So we done the lung biopsy for histopathological diagnosis of the malignancy, but there was no evidence of malignancy. Lung biopsy will be discussed by Dr. Divya. And as there was nerve and muscle involvement, so nerve conduction study and electromyography was advised. In nerve conduction study, there was generalized bilateral sensory plus motor axonal polyradiculoneuropathy, and in EMG there was generalized myopathic potential. So we thought that there is sensory plus motor neuropathy with muscle involvement. So it may be paraneoplastic, it may be due to IBM as age was suggestive, patient was of the old age, and there was involvement of the proximal muscles of the lower limb, or maybe it is secondary to multiple myeloma. So these were our differential diagnosis. So now I would like to invite Dr. Divya to discuss the lung biopsy and muscle biopsy finding.
Thank you, sir. So we received the lung biopsy, and here you see the representative images of the lung biopsy which show these alveolar septae. This is the interstitium. There is no thickening in the interstitium. There is no significant fibrosis or inflammation anywhere. And these are the alveolar septae and the alveolar spaces, which were also clean. So there was no atypia, no malignancy, and the lung biopsy was reported as no evidence of dysplasia or malignancy. Subsequently, we received the muscle biopsy with the classical history of an elderly patient with bilateral lower limb proximal muscle involvement and upper limb distal weakness, which was suggestive of IBM. And this is the muscle biopsy that you see. So this space is your epimysium. You see this thin space which is surrounding the muscle fascicles, which is the perimysium. And then when you go inside the muscle any fascicle, and you see this little space between individual muscle fiber, that is your endomysium. So there was no significant increase in endomysial connective tissue. If it would be present, it would be indicative of a dystrophy or some kind of replacement of the myofiber. You see these muscle fibers, they are nicely fitting into each other, creating almost like a jigsaw puzzle pattern. They have a kind of a mosaic appearance, and there is no significant abnormality that you notice within these muscle fibers. They are relatively of similar size. At max, you would say that they have a minimal variation in fiber size and shape. And as you keep going closer, you see that all the nuclei are nicely sitting at the periphery. There is no significant increase in internalization of nuclei and no abnormal inclusions present within the muscle fiber, which we would like to see in an inclusion body myositis. A word of caution here, if you send me a muscle biopsy in formalin looking for inclusion body myositis, even if it's a patient of IBM, you're not going to find it. The reason is that these inclusions get dissolved in formalin during the processing. So we classically want muscle biopsy as a frozen specimen fresh from the patient, and it is processed immediately. So when we did not find any inclusions and all the fibers appeared normal, we did go ahead with the special stains or the histochemical stains of the enzymes. This is NADH, which stains the type 1 and the type 2 fibers. You can differentiate the 2 fiber types on NADH. And here you see the nice mosaic of alternating type 1 and type 2 fibers, indicating that there was no abnormality. Again, you see the SDH stain, which is also highlighting the type 2 and type 1 and type 2 fibers, staining them differentially with a nice mosaic pattern, no abnormality. We also did the MGT stain, which is the modified Gomori trichrome stain, where if there would be any inclusions visible on HNE, they would get highlighted as red granular inclusions within the cytoplasm. So just to give you an example, this is another old case where we found these inclusions which appear granular and red colored on MGT. These were not seen in this case. We also did the PAS and DPAS stain. So this is PAS, again differentially staining the type 1 and type 2 fibers, fitting into each other like a mosaic. And the DPAS stain, because this material is glycogen which gets digested on diastase. So you see these clean muscle fibers with no PAS positive material, also telling you that there is no storage disorder happening here. But then there was obviously something wrong with the muscle, and on a low power we could see that these were the epimysial blood vessels which appeared thickened. A closer view of the same, this shows you this epimysial vessel which has this smooth muscle and some material which is getting deposited around the blood vessels. This was also present in the perimysial blood vessels, and you see the characteristic of this material, which is eosinophilic, that is, it is staining pink. It does not have any cellularity, so it is acellular. It has an amorphous with no classic appearance, but it has an amorphous quality and it is pale. This was also present in the perimysial blood vessels, so we suspected that it could probably be amyloid, and when we went back to the PAS and DPAS slides, indeed it was showing faint PAS positivity, as can be seen here. Even on DPAS, so you see DPAS, because there is no glycogen left in the muscle fiber, even on DPAS the same material around the blood vessels was staining positive. And we did the Congo red stain, which showed congophilia. Just to understand what is congophilia, when you look at the background color, it is pale salmon colored. But when you look at this material which is surrounding the vessels, it is showing you a darker color which we call as congophilia. It is this area that you want to see under polarization microscopy, which is salmon pink colored. And of course, the Congo red stained slide, when we subjected it to light to polarized microscopy examination, it showed this beautiful green color birefringence. If you've ever had a green apple, you would have no difficulty comparing the color. It's the apple green birefringence of amyloid. And so a diagnosis of amyloid myopathy was rendered. Just to give you an idea, amyloid myopathy is a relatively rare condition, and most of the deposits would be present in interstitial or perivascular location, although they can also be endomysial, which were not seen in our case. This was a study of 16 cases who found around 5 cases associated with the malignancy. And it is not uncommon for amyloid myopathy to present clinically as an inflammatory myositis, which was similar to our case. Another word of caution, extracellular amyloid deposits can very well be found in sporadic inclusion body myositis. So just finding amyloid does not mean that you're not dealing with a case of IBM, and you do need to examine the muscle fibers individually, because as I showed you, this is what you expect in a case of IBM, where you see these granular kind of inclusions within the muscle fiber which are basophilic on HNE and appear positive red on MGT stain. This was a study from Mayo Clinic where they tried to characterize over 18 years 52 cases of amyloid myopathy, and they found that around 14 were related to genetic abnormalities including dyspholinopathies, anoctominopathies and non-anodysfolinopathy cases, and around 38 were systemic. So for the further workup of the cause of amyloid myopathy in this case, I'll invite Dr. Satyendra sir to discuss.
So for the further workup, as our differentials were malignancy, sarcoidosis and multiple myeloma. For the malignancies, we done lung biopsy which was suggestive there was no any malignancy, and CT abdomen and thorax, there was no any sign and symptom of malignancy, there was no lymphadenopathy, so it was ruled out. For the sarcoidosis also there was no any granulomatous finding on the histopath, as well as serum S levels were normal, so it was also ruled out. So we were left only with multiple myeloma with myopathy as well as neuropathy. Suggestive features were anemia, raised ESR, hypercalcemia, proteinuria and few lytic lesions over the vertebra which were seen in the CT. So further investigations were planned for the diagnosis of the multiple myeloma. So on the serum protein electrophoresis, there was the M spike in the gamma region. There were 2 M bands were detected, and there was altered kappa and lambda ratio with abundance of the kappa light chain, and beta 2 microglobulin was raised. So we diagnosed is as a IgA myeloma. For the diagnostic criteria of the multiple myeloma, we need 2 things. First mandatory criteria is malignant plasma cells in the bone marrow more than 10% which are monoclonal, and any one of the following, that is raised calcium, renal dysfunction, anemia, lytic lesion, and serum free light chain ratio more than 100. In our case, calcium was 13 and there was proteinuria but creatinine was less than 2, and there was anemia with few lytic bone lesions, and light chain ratio was more than 100. So to document the malignant plasma cell in bone marrow, we proceeded for the bone marrow biopsy. So I would like to invite ma'am to discuss the bone marrow aspiration and biopsy finding.
So subsequently, we received the bone marrow aspiration and biopsy, and here you can see the aspirate smears which appear cellular. If you can see, these are the cells which were the predominant component of this aspirate. They were predominantly plasma cells, and this is the characteristic morphology that we teach our MBBS students. You have an eccentrically placed nucleus with moderate amount of cytoplasm which is amphophilic, so it has both a pink and a blue color. This is the characteristic paranuclear HOF that you see, and we did have the typical cartwheel chromatin with clumping of chromatin at the periphery and a central dot. Also, there were some immature forms which had a larger nucleus, had a prominent nucleolus, and also had a relatively small paranuclear HOF. This was the bone marrow biopsy. So you see this intratrabecular space, these are the true bony trabeculae, and in between you see a space which is definitely hypercellular for age. So for a 61-year-old male, you would expect around 40% cellularity, but this is nearly 60% or so. And it had these sheets of plasma cells sitting in the interstitium, again with the classical morphology of a cartwheel chromatin. If you can appreciate this one right here, you have peripheral chromatin clumping and a central dot. A higher power view of the same. So in this bone marrow, we had around 45% plasma cells with both mature and immature forms, and hence a diagnosis of multiple myeloma was established. Just to give you an overview, skeletal myopathy as an initial manifestation of myeloma has been reported in the literature with around 6 cases so far. And in 2 of the cases, interestingly, initially the muscle biopsy was reported as unremarkable, that is normal, and only after the marrow revealed an excess of plasma cells, when lambda staining was done in this case, they did find the deposits in the perivascular location. This was another case where the initial muscle biopsy was reported as normal, but later on, when 6 years later, when the patient did have myeloma, they found that the muscle biopsy did show some little deposits of amyloid which could be seen afterwards. It is mentioned that a diagnostic delay is often present in these cases of amyloidosis with a median of around 2 years, and in the first patient they found it around 6 years later. And the 4 other cases where amyloid myopathy has been reported in cases of multiple myeloma are these, with 1 case presenting with MGRS related amyloidosis which was complicated by an amyloid myopathy. For the final diagnosis and management, I would like to invite Satyendra sir.
So finally, our diagnosis was multiple myeloma, IgA myeloma with stage 3, primary amyloidosis with axonal polyradiculopathy and amyloid myopathy with anemia of chronic disease. So patient presented with muscle weakness, that was amyloid myopathy, and there was multiple myeloma. We started on the 12 cycles of the VRD regimen, that is the bortezomib, lenalidomide and dexamethasone after vaccination and pre-workup. And after 6 cycles of the VRD regimen, patient achieved very good partial response, that is more than 90% reduction in the plasma cell. And currently patient has completed 8 cycles, and our plan is to response the assessment after the completion of the 12 cycles. Thank you. Any question?
Very unusual case regarding this one, amyloidosis, because in the clinical presentation, one thing was that patient had hypercalcemia, but the blood pressure was normal. That is unusual.
Sir, there were 2 unusual findings. First, hypercalcemia without hypertension. Second, creatinine was not significantly deranged. Although there was proteinuria, but creatinine on multiple finding, it was less than 2.
So might be at that time, because whenever there is a hypercalcemia, often these patients have a hypertension. But this patient do not have hypertension. Even all the readings that you highlighted, that blood pressure was on lower side. Another important finding that is really unusual was that proteinuria of 342. Proteinuria of 342 is not I think 300 is we took as a cutoff when the patient already have some hypercalcemia. Hypercalcemia can cause tubular disorder, and this tubular disorder can contribute for some amount of proteinuria. And even the proteinuria of up to 1.5 gram we can consider as a tubular range proteinuria that can be expected when the patient have hypercalcemia. So proteinuria is again not too high when we are suspecting patient who have a overflow proteinuria, because multiple myeloma patients have a excess amount of protein production, and this excess amount of protein ultimately come in the urine, and these were estimated as increase in proteinuria. That is very unusual. And second is, might be this patient have some form of tubular disorder, because keeping this patient is not excreting any amount of protein. Most of the protein is likely to be absorbed in the proximal tubules. When these protein is absorbed in the proximal tubule, definitely there is some form of proximal tubular dysfunction might be there. Some Fanconi component might be, we can look in this in such patient, but now we treated this patient, definitely the patient showing response to this. So these are the 2 unusual things that might be, if we take in the earlier time whether we are dealing this patient, click a diagnosis, there is a hypercalcemia with normal blood pressure is inclined towards the multiple myeloma, amyloidosis. Thank you.
Yes, sir, it was very unusual that first patient was of the multiple myeloma, but there was very minimal renal involvement. Creatinine was less than 2. There was no significant proteinuria, although patient was having amyloidosis and amyloids were deposited in the muscle. And as ma'am discussed, that many cases has been reported in which there was muscle weakness and multiple myeloma was diagnosed after 2 to 3 years. But luckily we were able to diagnose because other features were there, and we were able to satisfy the criteria for the diagnosis. So by diagnosing the patient, we were able to manage the patient. Thank you, sir.
Good presentation, Dr. Satyendra. My only query is you said 8 cycles of chemotherapy has already been given, and he had a lung nodule. So retrospectively, what do you think is the cause of the lung nodule? Because biopsy has come out to be negative. Maybe it was missampled there. And amyloid, there are so many radiographic patterns of amyloidosis. It could be a nodular pulmonary amyloidosis. So what is your opinion about that?
First we thought that it may be old fibrotic lesion, maybe due to old healed tuberculosis, or it may be amyloid deposit as the sample, maybe the sample of the biopsy was not representative of that nodule. because the lung biopsy was absolutely normal.
Yeah,
So
that's what-
maybe
so,
we were not able to reach the nodule during the biopsy. Or
Yeah,
that,
it might have been missampled. There can
Yeah.
be a sampling bias, but tuberculosis, there was no other evidence of
no other
tuberculosis
evidence was
in the
there.
lungs at all. There was just pleural calcification, which was plaque-like. Yeah, but one advice is that while we are doing follow-up evaluation, you're going to obviously evaluate the response assessment by hematological and other parameters. So one advice is that we can do a low-dose CT chest to confirm that if it was amyloidosis, it might have also responded to the treatment. And maybe if that nodule has disappeared by now, it will be a therapeutic response assessment on imaging that this was indeed, even if it was missampled, it was indeed a amyloidoma which has responded to the treatment. So we can come to a really objective evidence of response assessment. Thank you.
Yes, ma'am. Thank you. Thank you. Okay, thank you.